Want to welcome you all. Thank you for joining us for today's presentation, specifically for payers. I'm Adam Rossi from the Stakeholder Engagement Unit at the Workers' Compensation Board. And today we will be sharing the latest updates on several initiatives that are helping to make the board better for payers and for the workers' compensation system overall. On hand to assist with your questions today, we have Dina Jones and James Wessel from our Office of Operations and Programs. And we also have Dr. James Tachi, the board's medical director, along with Audrey Cunningham, Paula Rauch, Christopher Failing, and Eileen Moss from our medical director's office. We are going to be taking your questions via the chat feature. If you look on the bottom right-hand side of your screen, you'll see a little chat bubble. Just click on that. Chat box will pop right up. You can enter your questions at any point. We are going to wait till after the presentation to take any of your questions, though. We will answer as many of your questions as we can, but if you have a question that we don't get to today, or if you think of something after the session ends, we will be providing you with resources at the end of the presentation. Also, I want to point out that your name and email were given to us when you signed in today. However, if you have a specific topic you'd like to discuss more deeply with the board, please feel free to share that topic along with your email address in the chat box so the appropriate board staff can follow up with you. The chat settings are set so that only panelists can see your questions or comments that come in, so you do not have to worry about others seeing your personal information. So with that, let's go ahead and get started today. Now, we do recognize that there's been a lot of activity and communications from the board on various initiatives. So we just wanted to make sure that you, and we want to remind you of some of our latest initiatives and provide you with a few new updates. We also would like to give you an opportunity to ask questions at the end of today's presentation. So to start, we're going to be reviewing some of the recent changes to board forms, including disability benefits. Next, we will share some updates to Onboard, followed by a review of the board's recent permanent telehealth regulations. We will then review the recent updates to disability regulations, followed by some reminders regarding CMS 1500. We will also review important information about workers' compensation as it pertains to COVID-19. Finally, we would like to remind you of helpful tips for efficiency when filing board forms, and so we'll review any additional resources you have available to you as well. And again, as I said, at the end of the presentation, we will leave time for your questions. So to start, as I mentioned, we have some new changes to some board forms. First of all, legislation was recently signed that took effect on January 1st of 2024 that removes the notarization requirement and allows affirmations to have the same force and effect as affidavits. To reflect this legislation, the board has updated several forms that previously required notarized affidavits to remove the notarization requirement and allow affirmations under the penalties of perjury under the laws of New York with the same force and effect as an affidavit. These include the forms you see listed on your screen here, as well as a handful of others. And the updated forms include the list, including the list on the screen can be found on the forms section of the board's website at wcb.ny.gov. The board also posted updates to the Form DB 450 to the form section of the website, and the new Form DB DEN, which will be available upon request. Please note that the failure of the employer to fully or adequately complete the employer's information section, which is Part C on Form DB 450, is not a valid basis for denial of the claim. The DB-DEN form must be issued within 18 days of receipt of claim or the claimant's first day of disability, unless Form DB 451 is issued within this time frame. If the DB 451 form is issued within 18 days as described, the DB-DEN form does not need to be issued. Neither Form DB 451 or Form DB-DEN will be available for download on the board's website, so rather, insurers and board-approved self-insurers may request them by contacting the Board Forms Department. The board has also revised Form DB 271S to simplify the language and ensure conformity with other board-issued materials. Please be reminded that when an employee is absent from work for more than 7 consecutive days due to a disability, the employer must provide the employee with Form DB-271S within 5 business days after the employee's 7th consecutive day of absence, or within 5 business days after the employer has received notice that the employee's absence is due to disability, whichever is later. For more information regarding the new and updated forms, you can email regulations@wcb.ny.gov. We would also like to remind you of the new travel reimbursement rate. In accordance with the New York State Workers' Compensation Board resolution adopted on February 20th, 1990, the board publishes the mileage rate for reimbursement to injured workers for travel by automobile on or after January 1st of each year. The rate on or after January 1st of 2024 is 67 cents per mile. In the instances where injured workers are entitled to reimbursement for travel expenses, insurers will reimburse injured workers for travel in accordance with this rate. So the board continues to make improvements to our new business information system Onboard, and we have a few new updates we'd like to share with you. First, we'd like to give you a quick update on the system itself. Since its launch in March of 2022, more than 1.5 million PARs have successfully flowed through the system. Today, healthcare providers and insurers are using Onboard to request and review prior authorization requests for medication, durable medical equipment, and treatment and testing. And we have hundreds of these PARs successfully flowing through the system each day. Nearly 54,000 healthcare providers have registered for Onboard, and more than 41,000 delegates have been added. 100% of the medication, behavioral health, and durable medical equipment PARs are resolved within 3 days, and most other PARs are resolved within approximately 2 weeks. Approximately 95% of these are resolved at the level 1 or level 2 stages of review, meaning without escalations. Over the course of the year, the board has made over 75 system enhancements in direct response to feedback from providers, payers, and other users. Lastly, the board has reduced the backlog of level 3 prior authorization request reviews from 8,000 down to 0. And over the past year and a half, the board has been steadily working to reduce the level 3 PAR review backlog, using data to identify problem areas, implementing new processes, and adjusting staff resources. Thanks to this effort, every level 3 PAR review is now handled within 2 to 3 weeks. The board also recently implemented the use of multi-factor authentication for accessing Onboard. It requires users to provide additional verification information beyond a username and password to gain access to a resource such as an online account. We've also made some recent changes pertaining to providers within Onboard, but we do want you to be aware of them as well as payers. As of February 8th of 2024, delegates can now submit PARs and escalate level 2 medication PARs for review. Previously, delegates were able to draft both, but were unable to submit or escalate. Authorized providers can also assign delegates, such as their office support staff, to assist with the following: drafting and submitting PAR escalations to level 3 from MDO review, responding to insurer requests for information, and drafting and submitting Form HP 1.0. Once a PAR is submitted, you, the payer, have a set number of days to respond. Response requirements vary for certain PAR types. Responses for MTG confirmation are required within 8 business days, and responses are not optional. MTG variants and MTG special services responses are required within 15 calendar days, but the response time is extended to 30 days if an IME is requested. Non-MTG over $1,000 responses are required within 30 calendar days. Non-MTG under or equal to $1,000 responses are required within 8 business days. And medication and durable medical equipment responses are due within 4 calendar days. These timeframes may vary based on weekends or holidays, depending on when the PAR is submitted. Please note, if the wrong PAR type is submitted by the provider, it is appropriate to deny the PAR and mention why in the comments section. So for example, you would say a confirmation PAR was submitted when a special services PAR was required. If the provider wants the service, they should resubmit as a special services PAR. You can also view this chart on the payer overview chart at wcb.ny.gov/onboard. And we will be sharing some tips for PAR handling efficiencies later on in the presentation. Also, please be advised that effective March 1st of 2024, any Form HP 1.0 submitted to the board without proper documentation will be rejected. Payers are required to pay a healthcare provider's bill in full, assuming it is consistent with the applicable fee schedule, or submit Form C8.1B within 45 days of submission. If a payer fails to do this, the healthcare provider may be able to request the board's assistance by filing Form HP 1.0 through Onboard. Healthcare providers must provide supporting documentation with every submission of Form HP 1.0, even if documentation was previously submitted to the board when the bill was initially sent. When submitting Form HP 1.0, providers must also attach the basis for provider belief that the clinical intervention was medically necessary, and any payer denial communications, if received, and scenario-specific documentation. Speaking of Form HP 1.0, I want to briefly highlight a new medical billing disputes resource you may find helpful. Accessible via the link on your screen or by searching medical billing disputes from the board's homepage. This new webpage shares everything payers and providers need to know about the billing dispute process, from detailed instructions and submission requirements to information on arbitration, including scenarios. As a reminder, the board has procedures in place to ensure all parties get paid in a timely manner. If a payer has not paid a healthcare provider's bill, the provider may be able to request board assistance by filing Form HP 1.0 online through the board's business information system Onboard. Form RFA2 has been modified to better align with the process for resolving payer denials of the Workers' Compensation Board's New York Medical Treatment Guidelines, known as MTGs, variants, and MTG Special Services PARs. If the provider escalates such a denial for MDO Level 3 review, any determination issued by the board's medical director's office in its notice of resolution is final and not subject to review for medical necessity under Workers' Compensation Law Section 23. As such, the payer may not dispute payment based on medical necessity, including whether such treatment or medication is recommended by the MTGs. This determination does not resolve any outstanding legal issues related to the claim, including but not limited to causal relationship and or acceptance or establishment of a condition or body part. In those instances where the claim administrator has specifically raised the issue as to whether the condition or body part is established as causally related to the claim, payment for any services provided in relation to this condition or body part are not guaranteed by this notice of resolution, and any dispute to payment related to the issue of causal relationship raised by the payer on a C8.1B after the treatment is rendered may be resolved in favor of the payer. An injured worker or injured worker's representative may request further action on all or part of this decision by filing Form RFA-1W or a RFA-1LC, respectively. A payer may not request further action on this decision, but may continue to pursue resolution of any outstanding legal issues as necessary. So, for example, if a payer contends that future treatment is not related to established site or condition, they should submit Form RFA-2 with the applicable request reason selected. Upon the filing of Form RFA-2, identifying unresolved outstanding legal issues pertaining to the treatment addressed by the MDO in its notice of resolution, The board may refer the outstanding legal issues to conciliation for a proposed decision or to a hearing. The updated version of Form RFA2 has been available as of December 4th of 2023, and the prior version is no longer being accepted. So what's next for Onboard? Rather than releasing Onboard all at once as a large-scale initiative, the board plans to develop the onboard system improvements as a series of smaller, discrete projects that will be released incrementally. The system upgrades will use web-based platforms and electronic data, increasing our ability to enhance these systems over time. We expect that this approach will enable the board to be more responsive to stakeholder feedback over the course of this multi-year program. Currently, the board is advancing the onboard program by focusing on two key areas. The first area of focus is the board's expansion of the use of e-forms and the development of APIs to streamline data submission. The paper versions of the Form RFA-1LC and Form RFA-1W are transitioning to an e-form with an intelligent online submission and routing process, although the payer-based process will still be available for injured workers who need it. The new process will be wizard-based, which means it will walk users through fillable fields for a new e-form. The wizard will provide numerous fields for attorneys to enter pertinent information, allowing for quicker, more efficient board processing and response. Additionally, attorneys will also have the option to submit Form RFA-1LC via an application program interface known as API. APIs enable independent computer systems, such as stakeholder systems in the boards, to talk to one another and exchange data, automating processes and reducing the need for stakeholders to manually enter data into web-based e-forms. When used correctly, APIs will be transformational in terms of providing faster, more efficient workflows compared to current paper-based forms. The schedule for these efforts is in development, and the board is committed to keeping stakeholders informed as our planning efforts progress in a timeline is available. Second area of focus involves the collaboration of various board divisions to formalize future processes and requirements for the new onboard system, in addition to engaging our external stakeholder community. Understanding all processes and requirements will help us design and build a more intuitive, user-friendly system that benefits all board stakeholders. We are excited about these onboard initiatives, and we do look forward to sharing updates on our progress in the coming months. But in the meantime, if you need a refresher on onboard, you can visit the payers page at wcb.ny.gov/onboard-payer overview. You'll see that link on your screen. As a reminder, telehealth is now a permanent part of the New York State workers' compensation system, following the adoption of a regulation that was many months in the making, with several iterations and rounds of public comments. We are very happy to now have this in place, but I briefly want to share with you how we got here and what it means. In New York State, telemedicine was an option before COVID-19, but it was limited to phone calls to discuss test results in lieu of an in-person visit and within a finite time window. During the pandemic, emergency telehealth regulations significantly increased and permissible uses of telehealth on a temporary basis to ensure continuity and access to care. Emergency regulations were extended multiple times. A 2021 study by the Workers' Compensation Research Institute found that telemedicine is changing the way healthcare is delivered on a national level. And as of the first quarter of 2021, use of telemedicine for evaluation and management services was still higher than prior to the pandemic. However, post-pandemic, physical medicine visits had returned to near pre-pandemic levels. Costs for services that were delivered both via telemedicine and in person were generally similar. The number of visits per patient when telemedicine was present, relative to only in-person care, was larger when follow-up visits were a mix of telemedicine and in-person services, and smaller when all follow-up visits were delivered exclusively via telemedicine. The board's permanent telehealth regulations have gone through several iterations, as we said, with extensive stakeholder input and the new permanent telehealth regulations took effect on July 11th of 2023, following the expiration of the last set of emergency regulations. So now let's dive into some of the details surrounding the new regulations. The newly enacted New York State regulation states that telehealth appointments may be performed by physicians, podiatrists, psychologists, nurse practitioners, physician assistants, and licensed clinical social workers through two-way audio-visual or audio-only communications. The provider must also be available for an in-person visit within a reasonable travel time if necessary. An in-person visit may be required, as may be specified in the MTGs, or based on the clinical age or stage of the condition as follows. The initial visit, every third visit, if acute or subacute, every 3 months if chronic but not at MMI, and annually if chronic and at MMI. For psychologists and licensed clinical social workers, telehealth should be permitted for the first and subsequent visits, including group therapy, irrespective of the clinical stage of the condition. Remote behavioral health visits should be limited to situations when there is no benefit to in-person services versus remote services, or when an in-person visit poses an undue risk or hardship on the patient. The reason for the use of the remote telehealth visit should be documented within each use of the telehealth visit. Treatment may not be rendered via telehealth for chiropractors, acupuncturists, physical therapists, or occupational therapists. Telehealth appointments that have been scheduled prior to the effective date of the new permanent regulations do not need to be changed to in-person visits in order to conform to this regulation, and the use of telehealth should not be the sole basis for challenging the results of such visits. However, any appointment scheduled after July 11th of 2023 must conform with the regulation. The regulations also delineate various clinical scenarios that indicate an in-person exam may not be necessary, such as routine follow-up appointments after a comprehensive initial in-person exam has already been conducted, or to discuss test results and/or counsel on clinical options. And when an in-person exam is necessary, such as to perform procedures, emergencies, eye conditions, nuance or complex issues, etc., or when an in-person physical exam might reasonably impact the accuracy, quality, or certainty of the assessment, treatment, or recommendations. Some scenarios do require an in-person visit. They include, but are not necessarily limited to, urine drug testing, appointments to determine permanency, impairment or disability, initiation of a chronic medication, or if the patient lacks the technology, capacity, or the desire for telehealth visits. We are frequently asked whether IMEs can be performed via telehealth. It should be noted that technically IMEs are not considered treatment. So with respect to performing IMEs remotely or virtually, this is permissible if all the parties agree, and as long as the IME is not being performed to determine permanency or permanent impairment. And as I mentioned, these regulations did go through several iterations incorporating extensive stakeholder input, so we do believe that these newly enacted regulations strike an excellent balance of that input. Since implementing the permanent telehealth regulations, the board has received inquiries regarding the proper method for payers to object to treatment via telehealth in instances where the payer believes the use of telehealth was inappropriate and inconsistent with the regulation. When a payer believes that treatment by a physician, nurse practitioner, physician assistant, or podiatrist via telehealth has been provided improperly pursuant to Section 12 of the New York Codes and Rules and Regulations, Section 325-1.26B1, the fact that medical treatment was provided via telehealth should not be the sole basis for a legal objection to a bill for such treatment, and the services should be reimbursed unless they are such that telehealth is clearly precluded by the regulation. Otherwise, for example, an initial visit with a provider or visits to determine permanent impairment. In other more nuanced instances where the payer believes that medical services for a physical injury or illness are being improperly rendered via telehealth, the services should be reimbursed, but the payer may request that future similar services be conducted in person by filing a Form RFA2. The payer should check box K, as in Kellogg, and request a direction for a future in-person visit in accordance with the regulation, and state why the visit should not be performed via telehealth. If a board order to conduct a specific clinical service in person instead of via telehealth is ignored or otherwise disregarded by the provider may be subject to administrative action. The payer should not file Form C8.1b. The filing of Form C8.1b in these instances will be found moot. Treatment rendered by chiropractors, acupuncturists, physical therapists, and occupational therapists under the New York Workers' Compensation System may not be rendered via telehealth. When a payer believes that treatment has been improperly provided via telehealth by one of these provider types, the payer may file Form C8.1b with the Other box checked and noting in the description that the provider type is not permitted to perform medical treatment via telehealth. As the board continues modernizing and improving stakeholder interaction with our systems, we look back on our official transition to the CMS 1500 form, the Universal Medical Billing form, over a year and a half ago. Since July 1st, 2022, nearly 10 million CMS 1500 forms have been submitted, including nearly 3 million electronic submissions through an electronic submission partner. More than 11,000 providers have submitted their CMS 1500 forms electronically through an electronic submission partner. The board transitioned to the universal form to reduce the administrative burden on participating providers who previously had to use separate board-specific forms for their workers' comp patients. Since July 1st of 2022, healthcare providers have been required to use the CMS 1500 for all workers' comp medical billing. Electronic submission through an electronic submission partner is strongly encouraged, although it's currently not required. As part of the initiative, the use of prior medical billing reports, including the Form C4 and Form C4.2, have been discontinued. Insurers are required to pay or object to a healthcare provider's bill within 45 days of receipt. Insurers are required to use the new Form C8.1b and Form C8.4 with applicable claims adjustment reason codes, otherwise known as CARCs, to object to medical bills. Workers' compensation payers will electronically transmit EOBs and EORs to their electronic submission partners upon adjudication of the assorted electronic CMS 1500 medical bills. We do want to note, however, that provider types who are not permitted to opine on causal relationship or level of impairment are not required to submit this information. As a reminder, payers are required to pay a healthcare provider's bill in full, assuming it is consistent with the applicable fee schedule, or submit a Form C8.1b within 45 days of submission. If a payer fails to do this, the healthcare provider may be able to request the board's assistance by filing Form HP 1.0 through Onboard. A complete medical bill must, by definition, include a CMS 1500 and the supporting medical narrative. The board has developed a medical narrative report template that can be used to create the medical narrative report that accompanies provider submissions of the CMS 1500 form. Providers should use this report when submitting CMS 1500. The board strongly encourages providers to include the three elements, which are the causal relationship, the work status, and the temporary impairment, in every clinic note, because that information is so frequently essential to the seamless administration of claims. There are several instances, however, in which this information is not as critical to the payer or the board, and it is not needed to properly adjudicate the medical bill. One example is a claim in which the injured worker has reached maximum medical improvement, otherwise known as MMI, and a permanent partial disability, or PPD, classification has been made. Moreover, certain provider types are not permitted to give formal opinions on causal relationship or degree of impairment. Please note the CMS 1500 initiative does not change anything related to a payer's assessment of causal relationship. It merely informs providers that causal relationship is to be reported prominently in the medical narrative. A PDF of the report, as well as a chart listing medical narrative report requirements by the provider type, can be found at wcb.ny.gov/CMS1500/requirements under the medical narrative requirements section. We urge you to share this template with providers if you notice it's not being used. More information on the CMS 1500 initiative can be found at wcb.ny.gov/CMS-1500, or you can email cms1500@wcb.ny.gov with questions, and we will have that link and that email up for you later in the presentation in case you can't jot it down right now. As a reminder, workers who believe they contracted COVID-19 in the workplace may be eligible for workers' compensation benefits. As payers in the workers' compensation system, you provide crucial benefits to both employees and employers. The employee receives the lost time and medical benefits stemming from a compensable claim, and the employer has the peace of mind knowing its insurance coverage will ensure that employees are covered. We strongly advise you to be proactive in distributing information about how to file a COVID-19 claim. Employees should be encouraged to file a claim if they feel they contracted COVID-19 at work. Also, encourage employers to help their workers file claims and remind them that it is illegal to take any disciplinary or discriminatory action against employees who file or wish to file a claim. Please review all claims carefully and timely, even if a medical report has not been received. And for more information on COVID-19 and workers' compensation, you can go to our special COVID-19 section on our website, which is wcb.ny.gov/COVID-19. So as promised, we are now going to review some tips for efficiency. But before we do, we'd like to make you aware of our efficiency campaign. The board will be issuing regular efficiency updates via GovDelivery. If you are not already signed up to receive board notifications, you can do so by visiting the board's website at wcb.ny.gov. Scroll to the bottom of the homepage, and you can select Get WCB Notifications. You choose the types of messages you want to receive, so it's all up to you what messages you want to get. So to view the message that you see here on your screen, you want to visit the wcb.ny.gov. Scroll to the bottom of our homepage. You can select the board announcements. There's a section on board announcements. And then you'll find this notice here, which is dated February 29th of 2024. All right, so now let's take a look at some tips for efficiency when reviewing or filing forms and requests. We'll start with forms C8.1b and C8.4. Effective July 1st, 2022, payers are required to use the updated Form C8.1b and Form C8.4 to notify the Board of legal and valuation objections. Payers must use the same CARC and RARC codes on the EOBs or EORs sent to the providers. There are 4 scenarios when you should not be filing Form C8.1b or Form C8.4. The first is when the amount billed for a CPT code exceeds the amount designated by the applicable medical fee schedule, and the payer pays the bill at the medical fee schedule amount. The next is when the payer reduces the amount of the bill to 12, 15, or 18 relative value units for evaluation services and modalities, as set forth in the applicable medical fee schedule. The third is when the payer reduces the amount of the bill pursuant to a contractual agreement with the provider, such as the network or a PPO discount. And the fourth is when there is a duplicate bill. The reason for payment reduction or non-payment if it's a duplicate bill should be set forth on the EOB. Next, let's review some tips when filing Form RFA-1LC, Form RFA-1W, or Form RFA-2. To start, when filing any of these forms, please do your best to check boxes provided rather than using the other field. This can lead to problems such as examiner delays or mistakes as the examiner is interpreting the request. The board has specific procedures for checkbox items, but not for the other field. In certain instances, the examiner could send a claim down the wrong procedural path, which can delay a hearing. Also, selecting Other prevents the board from capturing data for reporting purposes. Also, please provide supporting documentation. This significantly decreases the workload for an examiner when reviewing RFA forms. Any relevant documentation not included or not found could result in the examiner sending back the requests. When responding to PARs, we have a few tips to enhance your experience. Payers should only use the Level 1 administrative denial disallowed when the condition or body part has been formally disallowed by the board. Payers should respond to PARs in a timely manner to avoid receiving an order of the chair or a notice of resolution from the medical director's office. Failure by the carrier to respond timely to PARs will result in a waiver of the carrier's right to challenge the PAR based on medical necessity. We have an important update here. As we previously noted, there is a new enhancement to Onboard through which the option body part or condition not accepted or established was added under the reason for granting without prejudice dropdown when responding at a Level 1 review. Previously in Onboard, payers at a Level 1 review did not have the option to grant without prejudice on the basis of the body part or condition not accepted or established. More information can be found on the payer section at wcb.ny.gov/onboard. Finally, the board would like to remind claim administrators to ensure timely filings of first report of injuries, known as FROIs, and to properly notify the board of the correct claim administrator. This will avoid untimely filing penalties assessed by the board's monitoring unit. This also helps provide accurate information to Onboard, ensuring PARs are given to the correct administrator. It is important to file a FROI 04 to contend that you are not the insurer. That will trigger the board to attempt to locate the correct insurer. Simply sending correspondence to the board indicating that you are not the correct insurer will not prevent a penalty. So as we continue to work on implementing improvements for payers, we are committed to increased communication with payers, such as this webinar and targeted emails. The board also has a special webpage for payers. Visit the board's website at wcb.ny.gov and select the payers link at the top of the page. We will be expanding the content of this page by creating a What Payers Need to Know briefing page that highlights key activities, much like we've done today. We also plan to continue engagement with all of our stakeholders, including payers, as the board continues its modernization efforts via the future expansion of the Onboard system. The board is also excited to announce the new one-stop shop for payers outlining what they need to know about navigating the New York Workers' Compensation System. You can see it right there. It is our payer toolkit. We are very excited about that as well. You should be receiving some more information about that via GovDelivery as well, so make sure you keep an eye out on that. For more information on Onboard, please visit wcb.ny.gov/onboard. Resources include a walkthrough of the registration process, video tutorials, and recorded presentations for payers. For more information on CMS 1500 form, please visit wcb.ny.gov/CMS-1500. And as I mentioned, we also have a dedicated mailbox to answer all questions pertaining to CMS 1500. You can email cms1500@wcb.ny.gov. Just note that there is no dash in the email address. If you have payer-specific questions, you can call the helpline at 877-632-4996. You can also visit our website at wcb.ny.gov and select the Payers link at the top of the homepage. For claim inquiries, please visit wcb.ny.gov/contact claims and submit your questions to Claims Operations. You can also stay informed by subscribing to get board notifications straight to your inbox by visiting wcb.ny.gov and selecting Get WCB Notifications at the bottom of the homepage. Again, you choose the topics you'd like to subscribe to. You can also follow the board on X, formerly known as Twitter, Facebook, Instagram, and YouTube for board news, project updates, trainings, and more. And I want to take this time to let you know that we are recording this webinar. We are going to be editing it and posting it on our YouTube page. We will also be providing you with a copy of this slide deck. So make sure you are signed up for those email notifications because we are going to be notifying you via email when those are available. So that does it for this presentation. I want to thank you for attending. And again, we are now going to take the time to answer any questions you may have. Feel free, again, there's a little chat bubble icon on the bottom right-hand side of your screen. If you click that, a chat box will pop right up if you don't already see the chat box up. And any questions you have, please feel free to enter in the chat box. We do have a number of questions that have already come in. I am now going to hand the floor over to our subject matter experts, and they're going to take a look at the questions and give you some answers. Thank you.
Thanks, Adam. This is Dr. Tachi, and I will take the first couple questions, and then I'll pass the mic to my colleagues on the panel. The first question that we received stated, do New York licensed physicians who complete level 2 PAR reviews require any additional New York certification in order to complete PAR reviews? And just to clarify, what the regulations say is that the level 2 PAR reviewing physicians have to be licensed in New York State or the state where the provider practices. So that there is actually not a specific requirement that they are licensed in New York State. We had the second question that came in states that, in short, they'd like to inquire about how best to address duplicate PAR requests that are submitted without any new pertinent information, stating that these requests, tend to come in and they generate considerable time and energy to respond to, including going through the PAR process, when there's not necessarily any substantially difference in the clinical status. So just to be clear, we have issued repeated guidance both to payers and to providers that if a duplicate or near duplicate PAR is being submitted, meaning the request for the same procedure, diagnostics, medications, etc., from a prior PAR that has already been denied, there has to be some substantive clinical change in status for the patient's condition or the claimant's condition that warrants their repeat submission of the identical PAR. For better or worse, from the payer standpoint, because this is a clinical judgment decision, that repeated or allegedly duplicate PAR does have to go through the PAR processing because the judgment has to be exercised in order to determine whether or not it was truly no substantial change in the person's condition or not. That said, if payers see a repeated behavior particularly by a particular provider in which they're submitting duplicate PARs with no substantive or material change in the patient's clinical status, just resubmitting PARs for the sake of resubmitting the same PAR with the hope of a different result. We don't want that to happen. So please feel free to bring those instances and with the documentation to our attention at the board, specifically to the medical director's office. And we're happy to, to review the situation and perhaps refer it to our provider compliance committee. And I will, again, pass the mic to my other colleagues on the panel.
Thank you, Dr. Tachi. This is Paula Rausch. I'm a nurse in the medical director's office. We have a question. What type of response should we be using for wrong PAR type, admin or medical? And if we deny as stated under medical, the PAR will then automatically escalate to a level 2 review, which isn't needed if we're denying under wrong PAR type. If you believe that the request is a wrong PAR type, that is not an administrative denial category and will need to be reviewed for medical necessity with a medical denial by the L2 if it's deemed not medically necessary. There are no administrative denials appropriate for that. The next question, are there any plans to lengthen DME PAR timeframes? They're often associated with MTG PARs that are a surgery, which have longer timeframes, and that is correct. However, at this time, there are no plans to change the regulatory timeframes. But what we have repeatedly encouraged providers is to submit the DME if it's related to postoperative items, submit the DME PAR after the surgical PAR has been approved, but before the surgery is actually performed and planned. That way the item would be reviewed prior to them actually needing it postoperatively, but it won't hold up or it won't be denied simply because of the time frames. I think there was another. Onboard allows for a reviewer to assign an associate user with the same role to allow them access to the PAR. Once an associated user has been added to the PAR, how does that user search, find, and access the PAR? It looks like the person has attempted to add associate users, but the users have been unable to access the PAR, and the PAR does show that their profile has been added as an associate user, but they're unable to see the PAR when searching for it. So when someone is added as an associate user, they're not actually going to have the ability to search for PAR numbers. So the user who adds them to the PAR would need to send them the PAR details link from the browser, and then they'll be able to access it that way. Also, just of note, workload admins have access to everything. So if you're planning on having a reviewer that should have access to all PARs, you may want to consider making them a workload admin for that PAR type. And one other question for PAR types. Which PAR type result in an order of the chair if a response is not submitted within the appropriate time frames? Technically all that are not responded to timely are could result in an order of the chair, specifically over 1K, under 1K, and DME will get an automatic order of the chair issued by the system. The other PAR types, for the most part, there are many procedures that will get the automatic order of the chair. There are some, however, that are forwarded to the medical director's office, and a notice of resolution is issued in lieu of the order of the chair.
So this is James Wessel with the Office of Claims Operations. A couple questions that I can answer. There was a question about the APIs that Adam mentioned earlier and whether the PAR process will have APIs available. Right now, well, the API options are being developed as new e-forms are developed as part of the onboard initiative going forward. So right now, the only API that's in development or even being planned is related to the RFA forms that are under development. We'd certainly love to expand the API option over time, and hopefully we'll get there. But APIs for PARs are not something that's on our table for development right now. There's another question about a medical provider who is treating claimants and submitting billing forms that are not the CMS 1500, and those are being objected to on a CA.1B, and that is The appropriate way to do that, there's not a special set of language or anything that should be used for that. It's just a denial because the proper form wasn't used. There was a question about when medical bills are paid but reduced based on established apportionment, and if there's requirements on how that reduction is conveyed. There are not separate requirements or additional requirements when reducing based on apportionment. And if the person who asked that question wants to put some additional information, maybe on case numbers or something like that into the chat, we can find someone to take a look at where there may be some issues. And finally, a question on filing C8.1Bs and C8.4s. If you are raising both legal and valuation objections, you need to file both forms at the same time. But if your valuations are only legal, that the bill was untimely or defective or not, whatever those reasons are, and that's your objection, you can just file a, you're not required to file a C8.4. It's just if the C8.1B is not ruled in your favor, you couldn't go back and then attempt to raise a valuation objection after the fact. So it's really a judgment call on your part whether you file the 8.4 or not. Oh, and I'm sorry, one more. We appreciate the compliment on the contact claims online form. We are always looking at ways to expand the information collected, the options of inquiries that can come through. So that is definitely something we're working on. And again, if anyone has specific suggestions, feel free to throw them into the chat and we'll take them into consideration.
This is Audrey Cunningham from the Medical Director's Office. I think there were a few last questions. There was a question with respect to apportionment, and we would say if you as a payer are objecting to an administrative award indicating that the bill was paid per an established apportionment, then simply submit proof of the timely payment as well as an explanation of benefits indicating the apportionment. And also there was a question with respect to withdrawing a PAR for a mistake, withdrawal of a PAR. That is something that we are looking into. We have heard that and we are looking into that. So thank you for that.
There's the question on whether or not a C8.4 is required when the carrier is changing a CPT code. The answer is yes.
All right. Thank you, Eileen. All right. So at this point, we are going to go ahead and end today's session. But before we do, I want to thank you all for joining us. We always appreciate your participation as always. Thank you to our subject matter experts for taking the time to answer your questions. And before you sign off, please remember, please sign up for emails. Go to wcb.com, wcb.ny.gov and scroll down to the bottom of the homepage, select Get WCB Notifications. We do also distribute information via social media, via Facebook, X, YouTube, and Instagram. And again, don't forget to visit the payer-specific page on our website, and we have that new payer toolkit, which is very exciting. And lastly, before you sign off, we will be directing you to take a brief survey. Your answers help us improve our future webinars, so we appreciate you taking a couple minutes to respond. Thank you again for joining us today, and please enjoy the rest of your afternoon.